Good afternoon. I am Dr. Vatsala Kamath, Professor, Department of OBG. Today we'll be talking about obstructed labor. The definition is one wherein, in spite of good uterine contractions, the progressive descent of the presenting part is arrested due to mechanical obstruction. The incidence is around 1 to 2%. So what are the causes of obstructed labor? One is, it can be a fault in the passage. So bony, that is the contracted pelvis and cephalopelvic disproportion, soft tissue obstruction like cervical or broad ligament fibroid, impacted ovarian tumor, non-gravid horn of a bicornuate uterus, or it can be fault in the passenger, that is abnormal presentations like transverse lie, brow presentation, then congenital malformations of the fetus like hydrocephalus, fetal ascites, double monsters, big baby. I think this should come first. Macrosomia, occipito-posterior position, compound presentations. Now what happens when a woman goes into obstructed labor? Let us imagine a woman with, say, cephalopelvic disproportion, and the labor is not going as planned. Now what's the anatomical changes? The uterus, as we know, the upper segment contracts and more strongly than the lower segment. Here, because of the obstruction, the upper segment contracts more and more, whereas the lower segment becomes elongated and thin. And because of the obstruction, the fetus cannot come down, probably because of a contracted pelvis or a cephalopelvic disproportion. And there's the demarcation between the upper segment and the lower segment is called the pathological retraction ring or the Banton's ring. Now, how about the bladder? Now, since the bladder is immediately in front of the uterus and the fetal head, because of the obstruction, can't come down, and the fetal head presses against the symphysis pubis, and the base of the bladder and the urethra are caught between the two. So the patient can't pass urine, and later they can even cause devitalized tissue, which can then form a vesicovaginal fistula later. So what are the effects on the mother? Because of the obstruction, she'll feel exhausted, she'll be dehydrated because of the prolonged labor, there can be metabolic acidosis, then later there can be genital sepsis, and as we said, this obstruction, if it is not relieved, can even give rise to a big catastrophe, and that is the rupture of the uterus. And later what can happen, as we already discussed, she can have vesicovaginal fistula, rectovaginal fistula, and even secondary amenorrhea due to, of course, if you have a rupture uterus, you might have the patient has a rupture uterus, the doctor might have to do a hysterectomy, or even because of the hemorrhage, she can have Sheehan's syndrome. Now, how about the effects on the fetus because of the obstructed labor? Because of the prolonged labor, there will be fetal asphyxia due to uteroplacental insufficiency, or even there can be a cord prolapse. There can be acidosis due to fetal hypoxia and maternal acidosis. There can be intracranial hemorrhage due to supermolding, and there, of course, there can be fetal infection. So let us imagine a woman coming with obstructed labor, probably due to maybe cephalopelvic disproportion or contracted pelvis. When you examine the patient, what will be the clinical features? First, of course, because of the obstruction, the patient is in agony. There will be features of exhaustion. Then When you examine the patient, abdominal examination, in a thin patient especially, you can actually feel the upper segment is separate, is hard and tender, and the lower segment is elongated and pulled up, and you might even feel the Bandon's ring and the taut, tender, round ligaments. The fetal parts and the fetal heart sound might not even be fetal parts might not be well appreciated, and the fetal heart sounds might be absent because the fetus is already dead inside. Then when you do a pelvic examination, you might feel that the cervix is thick, edematous, and there might be severe molding of the fetal head. And if there is maybe a cervical fibroid or there's a contracted pelvis, you might see that this is the cause for the obstruction. How can you prevent this? Because obstructed labor, as we know, has so many problems both for the mother and the fetus, and if left unattended, can even give rise to a big catastrophe, and that is the rupture of the uterus, which has great mortality for the mother and of course the fetus also. So how can we prevent this obstructed labor? Most important is that we should see if there are any factors that can produce a obstructed labor, like do a pelvic assessment, see whether there's a contracted pelvis or whether there is a cephalopelvic disproportion, whether there is a macrosomia or an abnormal presentations, which can then lead to obstructed labor. So, and if such conditions are there, it is better to do a cesarean section and then deliver the woman. Now, intranatally, if you didn't find these factors, intranatally, what can happen? You will maintain the partograph, most important, and that will give rise to, you can time if the labor is not going as planned, there is no descent of the fetal part, fetal head, and the cervical dilatation is not occurring as planned, then we might have to deliver the fetus probably by a cesarean section. Now, in spite of all this, if a woman comes with obstructed labor, now what do we do now? First, of course, we are going to take a quick history and then the examination of the patient. General examination, you might find that she is in agony, then there might be features of dehydration, and on per abdomen we have already told the findings. And the most important thing, one of the first things to do is actually you have to rule out rupture of the uterus, because if then immediately we have to do the laparotomy. So how do we know the woman has ruptured a uterus? She will be in shock. There will be thready pulse, BP will be low, there will be severe pallor, and on per abdomen, the abdomen will be distended, and there will be the free fluid in the abdominal cavity, and a quick scan will actually show all these things. So, first and foremost, you are actually seeing whether she has already ruptured a uterus. If that has not happened, the most important thing now is to relieve the obstruction at the earliest. In other words, you have to deliver the woman, and most of the time it will be by cesarean section. Of course, in the meantime, you're putting IV line, you're correcting her dehydration, acidosis, and IV antibiotics you're going to start. So, and all the blood tests are sent, and she is catheterized, and vaginal swab is sent for culture sensitivity. And as we already said, what would be the obstetric management? The first rule, as we already told, is to rule out rupture of the uterus. Now, once there is obstruction, of course, now if there is no rupture clinically and by other investigations, then we have to next deliver her. You're not going to wait, watch, not going to start oxytocin, understand? So, first is to deliver her. So, most of the time we have to do the cesarean section because of the mechanical obstruction, and then the patient will be fine. So, of course, the fetal outcome depends upon the fetal status at the point when she comes to you. And if the head is right down and you can apply even some instrument and deliver the baby. But most of the time it is the cesarean section is what we follow for delivering the woman. So, obstructed labor, as we have seen, is a very important topic both for a examination as well as in practice, because if you don't detect this, prevent this condition would be ideal. Then, if it is detected, then the management should be as I've outlined, otherwise, it can lead to catastrophe like rupture of the uterus and mortality of the woman. Thank you.